Good evening again, guys. And it's been a terrible technical challenge, but finally we are on. Um, so, if you're joining from your computer, you would have access to be able to send in your questions right from the start of the presentation. What you do is that if you look in the top right corner of the window, that's if you're using your computer, you look in the top right corner, there will be a rectangular tile. When you click on that tile, you should be able to see the Q&A app. When you click the Q&A app, you should be able to post your questions through that app. Okay. So today we have a presentation by Dr. Kojo Odronkroma on diabetes and what we need to know. Please start, posting your questions as the presentation rolls along. We're very, very sorry for this terrible delay. Okay, so I won't waste too much time. Dr. Nkrumah,
Yeah.
kindly take it away.
Okay. Okay, guys. Good evening once again, and I should say sorry for the delay as well. So today, as Richard rightly said, we're talking on the topic diabetes. What do you need to know? Uh, as the presentation goes on, I will just would like to maybe bring to your attention. I mean, why diabetes is such an important topic, medical or health topic to talk about, especially within our age group, and also the fact that there's a lot we can do in terms of helping ourselves with either postponing the onset of the diagnosis or preventing it and managing it. So basically, the outline of the presentation would be with an introduction that will give you a bit of bare facts into diabetes, and I'll share a few slides on what is generally called non-communicable diseases. I decided to put in this because diabetes, as we'll come to know, falls into this group of disease conditions, and it's become a very important cause of mortality, as in death, and then morbidity as in ailment or disability. And we'll roll quickly to diabetes, how it's managed, and then the problems associated with it. We'll talk about guidelines to diagnosis so that if you go and you do any test, your doctor will talk to you anyway, but just for you to have an idea of the path that you are on, whether you are gearing towards being diagnosed as diabetic or not, and who qualifies for screening, and why should you be screened, and then some few preventive efforts, and I will end with a slide on the hard facts of diabetes as presented by the World Health Organization, that is WHO. So NCDs you come to know are non-communicable diseases, and for this presentation, diabetes refers to the group, the condition known as diabetes mellitus, because we have another type of diabetes, it's diabetes insipidus, that you don't hear about because it's quite a smaller, uh, it's a smaller entity, and it has to do with your water balance, as opposed to diabetes mellitus, which is problem with sugar handling of the body. So when I say diabetes, worldwide now, diabetes really refers to this, the sugar type of diabetes. That's diabetes. Great. So as an introduction, uh, as I said earlier on, the burden of diabetes globally is becoming a big problem, and is even worse in developing countries, of which Ghana is part of. Like many of the non-communicable diseases, as I'll explain briefly, uh, the causation is complex. There's a lot of interplay between genetics and environmental and such and other, like factors as in, what you do. So it makes sometimes tackling the disease from the causation level very difficult because there's no one single cause or agent that you want to take away for you to get rid of this condition. So this is quite a complex combination of many things. But then the good news too is that there's good evidence that there's a large proportion of these cases of diabetes and its complications can be prevented. I mean, through healthy eating, regular physical activity, maintaining a good or normal body weight, and avoiding things like tobacco, which I know is not a major problem here. But then why we took on this topic is the fact that despite the existence of the possibility of this preventive approach, there's still evidence that is not widely implemented, and you agree with me as we go along that I mean it needs a lot of motivation and effort, in our times, in our circumstances, and in what we do for you to really take on some of these uh, preventive efforts. So next few slides we'll talk about.
Next few slides we talk about.
Sorry, hello, can you
Sorry,
hear me?
can you hear me?
Yeah. Yeah. Yes.
You can hear me. Yeah,
You can hear
I
me.
was
Yeah?
echoing back.
I was echoing back.
Yes. But you have the slide shared, please.
Yes.
Yes.
All right.
All right.
But I'm hearing
But I'm
myself.
hearing myself.
Okay, so I'll go on.
I'll go on.
Yeah. Do you have the slides shared?
Okay.
Because,
Okay.
do you have the slides shared? Your screen.
Yes.
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 Let me
Yes.
see.
Let me see.
Mm-hmm.
Mm-hmm.
It's
It's
it's shared.
the share.
Okay. Kindly pause and stop the share and reshare. Let's see, please.
Okay.
Okay.
Hello. Great.
Hello. Great.
No. Still hear
No,
myself.
no, no, no. Stay here myself.
Hello.
Hello.
Yeah.
Okay.
Okay.
Or I should just talk to
Talk to anyway.
Yeah. Let's go through.
it's just like I'm okay.
But I come. Okay.
Please
All
continue.
right.
All right.
So yeah.
So
Sorry guys.
yeah.
Sorry guys.
Sorry, guys. Sorry, guys.
So the next few slides, as
So
I
the next
said,
few
we'll
slides, as I
talk
said,
about uh, the communicable
communicable
diseases.
diseases.
And by the World Health
By the World Health
Organization
Organization
classification,
classification,
communicable,
communicable,
I mean
non
non-communicable
communicable
diseases are
diseases
found
are
on the second.
on the second.
These are disease
These are
conditions that
disease
are not
conditions that are not
transmissible by
transmissible
person-to-person
by
contact or
person-to-person
by
contact or
intermediary
parliamentary
organism or maybe
organism
through any
or
other
maybe
medium,
any
right?
other medium,
So as
right?
opposed to
So as
communicable disease,
opposed
which
to avoid it,
we
which
tend to say, let's say,
we tend to
infectious
say that
diseases,
the
for
infectious
example,
diseases, for example,
like malaria,
like
like
malaria,
hepatitis,
like
maybe
hepatitis,
gonorrhea,
like
HIV,
gonorrhea,
TB,
HIV,
right?
TB, right?
These
These
viruses,
viruses,
bacteria that you
bacteria
can
that can
get from
get
people
from
through
people through the
contacting,
contact,
as opposed to
as opposed
these
to this
communicable diseases
disease
that
that
are not
are not, you know,
transmissible just by
transmissible just
contact
by
or by
contact or
any
by
other medium.
any other medium.
And examples of
Examples,
these
these
non-communicable
non-communicable
diseases
diseases
are heart
are
diseases,
heart diseases,
stroke,
stroke,
cancer,
cancer,
chronic
chronic
lung
lung
diseases, right?
diseases, right?
And then what we're
And
going
then
to
what
talk
we're going
about, that is
to talk about,
diabetes
that is
mellitus.
diabetes mellitus.
So when you see
So when you
NCD
see
is
NCD is
non-communicable disease,
non-communicable disease, okay,
as I've said,
as I've said,
what we used to
what we
refer to
use
as
to
infectious
to other
diseases that
infectious
you get
diseases
from
that you
each other,
from
from
each other from
vectors, and
vectors, and
non-communicable ones
non-communicable
by contact.
by
They are not
contact, they are not
contagious, and they don't
contagious,
have
and they don't have,
person-to-person transmission.
person-to-person transmission.
So why did I
Why did
put
I
these few
put
slides?
this issue?
I did it
I
because
did it
the world
because
over
the world over
The developing world
The
is
developing
experiencing
world is
something
experiencing
quite
something quite
significant with respect
significant
to
with respect to
these new,
these
not
new,
new, these
not
non-communicable
new, these
diseases.
non-communicable diseases.
For, let's say, going back
For,
into like
let's
maybe
say, going
about
back into like maybe about
70, 60 years,
17,
a
16
lot of our
years,
disease
a
condition
lot of
barely
our disease
was
condition
from the
barely
infectious
was from the infectious
origin, like malaria,
origin, like malaria,
diarrhea
like
conditions,
diarrhea
typhoid,
conditions,
measles,
typhoid.
syphilis, gonorrhea, those ones. But we are now transitioning to have a lot more of the non-communicable diseases, which is a lot or used to be a lot common in the Western or the advanced world because they had transitioned from the infectious, to those types of disease conditions. So usually we have what we call this epidemiologic transition, where we have factors that combine our industrialization, our urbanization, and what this leads to is that yes, I mean people become richer, people buy cars, they can afford eating out and not eating healthy. So it leads to eating a lot of wrong things, fats, a lot of calories, you know, and sedentary lifestyle. As I said, for a lot of typical people working in Accra, except some few, you spend like about an hour or an hour and a half driving to work. You go to work for the next 8 hours. People sit, for like 7 hours or 7.5. Go for break for like 30 minutes. Close, step back into their cars. Another 1 hour, 1.5 hours back home. You get home, you are tired, you eat, you sleep. So in a day, your main physical activity is like barely like 2 hours or 1 hour. Weekends you can do something. You hop up and go for a funeral, you drive another 3 hours or 2 hours, you go and sit, you drink, you eat, you come back, you type. So that is this one. And generally as well on the economic and public health side, the other thing is that yes, I mean we are developing whether we like it or not in terms of it's debatable, like sanitation, public health interventions, vaccinations against a lot of these infectious diseases and all that. So yes, we are curtailing these infectious diseases at some point, and then people are living longer. Child infant mortality is getting better, and fertility is even going down. So we have a lot of aging population as well. I mean, for us, yes, I mean our life expectancy is increasing. We are having older people, and as we have older people, age itself is a risk. I mean, one of the factors in having non-communicable diseases. So, if you look at my pointer, you have, as I said, this feeding in and then this aging feeding in. So, this is what we have. We used to be here. This is time course, all right? This one, the horizontal axis, the vertical axis is like, dead weight. So, you're looking at people dying from either infectious diseases or from non-communicable diseases. Okay. And then if you look here, maybe let's say from 1920, a lot of our cases would have been like infectious diseases. With very little, hypertension, diabetes, and stroke and all that. But as time went on, and with the factors I showed in the previous slide, we have sliding down on the infectious diseases. Was with urbanization and all that, our non-communicable diseases that I showed you, heart disease, stroke, diabetes, lung diseases, and hypertension are climbing up. Okay, good. The problem with us in developing world in sub-Saharan Africa is the fact that in other parts of the world they had quite a big drop here in the infectious diseases before this one picked up. So by the time they picked up with the non-communicable diseases, they had really controlled the infectious diseases. In Africa, we have what we call like the double burden of diseases, meaning that our malaria is still quite a problem. problem. Diarrhea are still a problem. HIV is a big problem. TB is a big problem. But we are at the same time, because of rapid urbanization developing, also having a lot of these non-communicable disease burden here. So we are almost, maybe at this point, almost like a 60-40, 40-60. So we have to grapple with both at the same time, and it's not an easy thing, as I'll show you. So this is like mortality. We're looking at 2004 death, cause of death. Okay, by continents, all right, and it was updated in 2008. The deepest death actually from communicable diseases like infectious diseases, okay, malaria, HIV, TB. Talk about a few. While the lighter color is for the non-communicable disease like heart diseases, stroke, diabetes related conditions, and the injuries. I'll take that one out. So just take a look at it. Follow my case. So take Africa for example. You realize that if you take the male population, about 5 or 5 point something deaths per thousand are attributable to infectious diseases. Okay. Whilst you have about 2 point something deaths attributable to non-communicable disease. Okay. And look at the Americas, for example. Their death rates are generally low, but you realize that death from communicable diseases are almost nil. Okay. The same with Europe. A lot of their death is as a result of non-communicable disease. Right. And you take the high income is almost in terms of communicable disease. But although I say that these people still have a higher rate of non-communicable disease burden, you realize that the death from these conditions are still lower. And I will explain why as we get along. So this is the other problem that comes with managing problems with these non-communicable diseases. Okay. If you look at this table, for example, the cost of managing like malaria, diarrhea, measles by immunization, or pneumonia using like a cheap antibiotic that may work. Okay, you're barely hitting about $5. Okay, as a total cost for treatment. Compare this to managing the problems that come with non-communicable diseases like diabetes, hypertension, stroke. Renal is kidney. So diabetes is a major cause of kidney failure. When you're on dialysis, and this applies as well together, you're spending like about $1,200 a month. Okay. If you have diabetes, this is a moderate cost of about $60 per month on medications alone. Right. If you have heart diseases, you're spending that. If you have stroke and you are doing rehabilitation, they can't quantify it. But I work in a stroke unit and I follow stroke patients, and believe you me, in a month you will not spend less than maybe $100. Okay, if you want to do it well. So that is why if you go back, you realize that even we with our numbers, we're going to die more because the cost of managing the problems that come with the non-communicable diseases is high. That is why although the Western world have a higher percentage of people living with communicable disease, because they have money, they can still manage the problems associated with it to some extent. Okay, good. So in summary, I've just introduced ourselves to the non-communicable disease burden that these developing worlds are having. And I say that yes, these chronic diseases will be the most common cause of death within 25 hours in 25 years in all countries of the world. So we are looking at maybe like what, 2040? Okay, right. Poverty, as I try to explain, and established inequities are a major impediment to effective management of shifting epidemiology. But the good news is that there's proven effective and inexpensive strategies for prevention of these diseases globally. All right, that may not need too much money, but it needs the will and effort to do that. So we're going to pick one of these non-communicable diseases, that is diabetes, and talk about briefly. In time, we can look at all the others that come with it because they are quite important for us now. So diabetes, all right. So basically, when we eat, I mean, a lot of African and Ghanaian base, the base of our diet is carbohydrate or fat, and a lot of these is absorbed into our bloodstream as glucose, which is the body's number one source of fuel, right? Like petrol for car. And there are certain parts of the body that depend solely on glucose. Other parts can use other energy sources, but like the brain, for example, is so fine and it's like a vapor for maybe a Ferrari car. It can't use any other type of fuel, right? So this is what happens when we eat. So if you follow my slides, I'll run through this quickly. We get a concept and then we can move on very quickly, okay? So people who don't have diabetes, what happens is that when you eat, glucose stays in a healthy range in your blood because once you eat, the body releases insulin at the right times in the right amount. And this is very important. The body is releasing insulin. Insulin is like a chemical that is secreted from an organ behind the stomach sac, we call the pancreas. And stomach here is not abdomen. Stomach is the sac. If I talk about stomach, I mean the organ stomach, the one you eat and the food enters. It's not like your whole big belly, no. So as you eat, depending on the amount of glucose load and all that, the body responds very rightly to it by secreting the right amount of insulin, just to make sure that this insulin that is depicted here as I, okay, combines with certain receptors on the cells of the body, and once they combine and it's effective, they allow this glucose from the bloodstream to enter the cells because it's the cells that are going to use this glucose as energy, as fuel. Glucose in the bloodstream cannot be used unless it enters the cells. Okay, good. So this is what happens normally. So that at any point in time, your glucose in your bloodstream is very much regulated to normal limits. But in or people with diabetes, we have what we call high blood glucose. The high blood glucose is just that there's high blood glucose in your blood. Okay, this term we call it hyperglycemia. Hyper is just high, glycemia is just glucose. So hyperglycemia basically high blood glucose. All right. But in diabetes, there's a problem. You eat, the food get absorbed into your bloodstream. But then once it's in the bloodstream, there may be too little of insulin being produced from your pancreas. And because of that, they don't have a lot of insulin receptor bindings at the cell site to allow the glucose to go into the cells to be used. So glucose accumulates in the bloodstream. Or you may as well even have quite a good amount of insulin. But the insulin and the receptors at the cell, their relationship, okay, when they bind, how effective that binding is to allow the glucose to enter may also be impaired. So you realize that that one can also be a factor in terms of making the glucose stay in the bloodstream instead of shifting into the cells of the body. And then sometimes too, there may be too much release of glucose from the liver. The liver stores glucose and releases it when we don't have, but it needs to be informed by a lot of things. So even sometimes in the midst of plenty in the bloodstream, the liver is still releasing because it is being told that there's little glucose in the cells. Okay, so these are like three big mechanisms by which we have excess glucose in our bloodstream from. Okay, so diabetes basically result from that. Too little insulin from the pancreas, or it's not too little, it's okay. You could have managed with it, but it's because we have a lot of what we call insulin insensitivity. Insensitivity just meaning that this insulin binding to the cell side, the interaction is not good enough for glucose to move into the cells. Okay, so generally, when there's a lot of sugar in your bloodstream, okay, an abnormal amount of sugar in your bloodstream, it leads to excessive urination, all right, because the glucose, which you usually will not excrete in your urine, when this cuts above a certain threshold, you tend to, the kidney will filter it and it will go into your bladder to be passed, okay. And once the sugar is passing, it draws water along with it, like an osmotic effect. So you tend to pass a lot of urine. You become dehydrated, and then the body tells you that you are thirsty because you need to fill that water gap, the void that you are created. So you drink more. So you are drinking more not because, uh, okay, no. So a lot of people will say that, oh, okay, I urinate a lot because I drink more. You are drinking more because you are urinating a lot and you are becoming dehydrated, and the body is telling your system to let you drink. Okay, this is opposed to maybe somebody who's working out and being thirsty and you've lost a lot of water in sweat, so you drink. All right. So, but this is the diabetes cycle of drinking and thirst. That's how it is. Your vision might also be a bit blurred. You feel tired, and actually you have a bit of weight loss. You may have weight loss. Some people might have quite a drastic amount of weight loss. People get frequent infections like balls. You had two balls in the armpit. After 2 weeks, another ball. Those are some of the symptoms of excessive sugar in the bloodstream. Okay, good. But these are like short-term problems. Okay, but on the long term, diabetes or excessive sugar in your bloodstream causes a lot of damage to the vessels, the walls. So the walls of your vessels are so smooth that there shouldn't be any clot or anything. But with excessive sugar, these vessels lose a lot of their characteristics, the ability to expand and retract, and then the smoothness of their inner layer and all that. And since all these organs have a lot of vessels, tiny vessels in them, these damages will eventually cause damages in the organs as well. So you have blindness, you have kidney disease, you have nerve problems, amputation, heart attack, and stroke. So in the long term, yeah, these are problems with diabetes. That's why we manage or we want to treat this persistent high glucose in the blood in diabetic patients to forestall some of these problems. Two types of diabetes we have: type 1, type 2. Now we don't talk about, you say, oh, juvenile or adult onset, no, just type 1, type 2. What type 1 basically means is that the pancreas is producing, as in the previous picture, very little or no insulin at all. So there's something that's happening in the pancreas that's shut down in terms of production of insulin. Type 2, there's what we call the insulin resistance, where there's some amount of insulin being produced, but its interaction with cells for them to take up glucose is reduced, right? And then, but with the type 2 as well, with time, the pancreas as well loses its ability to produce more insulin over time. So they also tend to have insulin lack with time. Type 1 usually, uh, the majority of diabetes people, the type 1 are in the minority because of the way it comes about. And I'll show you because of what that type 2 really is. A lot more people are type 2 than type 1. Type 1 are mostly in children below 20 years. I say mostly because now things have changed. Those times, you used to see a 20-year-old, you are so sure it's type 1. But now because of our change in lifestyle, eating habit, and all that, obesity, even in the children, you can meet under 20-year-old with a type 2 type of diabetes. So basically, the type 1, typically, these are young, as in not, these are children really, whose pancreas has ceased producing insulin. And so the body can no longer make insulin. And for them, as I've explained to you, the treatment is basically with replenishing them with insulin. There's no way around it. Insulin. There's an initial treatment of choice and the only treatment they're going to need. Okay, basically, yes. For them, because it comes with a shutdown of insulin production, their symptoms really present quite acutely or quite maybe suddenly with loss of energy. They have disinhibited, they are urinating a lot, and sometimes vomiting. They become so dehydrated, they can actually go into coma if you don't get them early, and it can be quite a devastating condition. I mean, we've lost cases like that because they haven't come to us early. At the time they came, they were so bad that try as hard as we could, we still couldn't manage and for them to survive. That's the typical type 1. So as I said, with their management, these are people who need to take up. Uh, you need to educate them, healthy food choices. You can have some physical activity and all that. And but insulin is a drug of choice. Okay, good. For this picture needs to go for type 2. All right. So that's it. So before the insulin came into existence, type 1 was like a death sentence because, as I said, you lack it, you don't have it. Insulin is so vital because in the midst of abundance, the body still lacks. There's so much sugar in your bloodstream, but your cells lack insulin to function. And so the body just grants to a halt because the fuel just ain't enough for the system to work with. So see this boy here before treatment, almost like a malnourished staff boy, and just having started treatment for 3 months, you see the remarkable change. So that is what type 1 is. Now to type 2. Type 2 is the more common of the two types of diabetes. It's a lot more in older people, I'll say maybe above 30 onwards. They say 40, but now we are diagnosing it in a lot of people, 25 and above. Okay. And as I said, because of our lifestyle, you're having sometimes a few teenagers and people in around just 20s with type 2. And it's also more common in people who are overweight, non-Caucasian, as in our black population, and people with family history of type 2 diabetes. So if you have a mother or a father or a sibling with diabetes, especially mother, father, your chances of having diabetes is slightly higher than somebody who hasn't got that kind of relationship. So that's type 2, as opposed to type 1 that hasn't really got that kind of relationship, except maybe some very few other fine ones. Type 2, that's the thing about it, is that it can be very insidious. You can have some amount of hyperglycemia in your system quite a while before it even shows up with symptoms. So people can go with 2-3 years, without necessarily coming down badly with any acute illness or symptom for them to even know. Some will be picked up because they will just go and check. But they may also come down with increased tests, increased urination, feeling tired. They may have, blood vision and frequent infections and a bit of weight loss as well. And as I said, 1 in 4 people with type 2 may not even know that they have it. So, type 2 management as opposed to type 1, you realize that here the rating always includes, if you go back to your slides, which you will have a look at, in the type 1 management, it wasn't as bold as that. This is always include education, healthy eating, physical activity, and then your glucose monitoring. These are key in management of type 2 because one of the main or one of the important risk factors is maybe excessive weight, excessive fats, physical inactivity, wrong eating, and all that. So it's a cornerstone of management. Anytime if you have diabetes or you are diagnosed with diabetes, this is your starting point of management, and then you can add on the medication. So in type 2, we have tablets that you usually we start with, and then but at a point, every diabetic, type 2 has the potential of going on insulin at a point in your management if you have it. And going on insulin may not necessarily mean that the disease has become so bad or you are your case is I don't know how to talk about, like if your case is bad and worse, I don't know, it's worse than it can ever be known. It's just the way the nature of the condition. As I said, that with time your insulin production goes down, and try as hard as the medications will be, you still will need some amount of insulin to forestall all these complications. So uh, yeah, everybody should bear in mind, once you are type 2, you are started on tablets, you should know that you may be on insulin at a point in time, and it shouldn't scare you because it's actually trying to get into the body what the body actually produces as opposed even to the tablet. Type 2, as I said earlier, has certain risk factors. Risk factors will be basically these are certain attributes or conditions that make you a lot more susceptible to having a condition than somebody without these attributes. One is being overweight. Being overweight basically would be having what we call the body mass index of more than 25 onwards. All right, having a sedentary lifestyle, which I think a lot of us have now, and then having a family history of diabetes or history of diabetes during pregnancy, that is gestational diabetes. And as we grow, our risks become higher. And as I said, the black population too have a slightly higher risk. Diabetes can be a problematic condition because it affects almost every organ system in the body. It's one of the disease conditions that it affects everywhere there are vessels, as I said, and there are vessels everywhere from the skin to everywhere to the penis to the vagina, all of them. So diabetes has effect everywhere. And if I should just take you through some facts, in macrovascular, I mean these are medical terms, but is that diabetes of blindness in the adult working population. Okay, diabetes cause of kidney disease. If I say chronic kidney disease, it's like having what we call the end stage kidney failure that will need dialysis or transplant. Okay, diabetes is the number one reason why people who haven't had trauma in terms of accident or anything get their amputated. Okay. Apart from that, it has other conditions like affect the nerves, so they have those burning sensation. You don't even feel pain. Put their electric hot water, then they think that they've been bewitched. Because I've heard the vessels, you can also have erectile, if you can manage your diabetes well. For the men, there's a lot of erectile issues with it. And even for the women as well, like libido and all that goes down. It's also an important cause of stroke and heart disease. So it's such an important condition because latent effects are quite expensive to manage, and the disability that comes with it can be very expensive as well. Good. So basically, diabetes is that. In Ghana, you would think that yes, I've shown you that the developing world is having a problem with this condition. But then look at this. In 1950, one of the studies conducted to look at the population prevalence actually is like the number of people living with a condition at a time. Okay, so those who have just been diagnosed, and those who've been diagnosed, up until the time that you are doing that study, that's the prevalence. The data community in whole, it was 0.2% really. So if you take every 1,002 people, okay, that's 1950s. Now roll back, or roll forward, sorry, to 2009 in Kumasi. They found a prevalence of 6%, and this is just barely like 50 years interval, like 60 years interval. Accra the same, 6.4%, and it's even worse because among civil servants, it's as high as 9.1%. So every 100 people, you have like 9 of them being diabetic. Okay, so this is how bad it is becoming now. And I said it's an expensive disease. From our own Atipu's work he did, with this cocoa clinic patient. Per patient, you're looking at about $380. He costed about $380 for a year, which now will be about, if it's 400, let's say for almost like 1,005. All right, okay. But even in as far back in 2007, Kolebu was recording about 700,000 to just to manage diabetes in terms of medication and hospital visit. Now, I bet you these figures will be maybe double and triple. So, managing it alone is expensive. Managing the complications is even more expensive, and the prevalence is rising for us. Good. So, who or how do we diagnose you as having diabetes? Basically, it has to do with checking your plasma glucose, and either at the lab or when they procure the glucometer. So for us, if you have a fasting plasma glucose, if you fast, and fasting really means going 8 hours or more without any calorie intake. Calorie intake is anything that will give you glucose or energy. I mean, like those who are carbohydrate fat and all that. So minimum 8 hours. Okay. But you usually wouldn't check after 13, 14 hours, between 8 to 12 hours. Okay. If you check and it's more than seven or more, or we have what we call the oral glucose tolerance test. For those of you, they go to the lab, they give you a certain amount of glucose mixed with water, usually 75 grams of dry sugar. Okay, they put it in water, you drink, and then they check your sugar every 30 minutes. 2 hours after that test, if your glucose in your blood is more than 11.1, okay. But sometimes you just catch some people that random means that you can't really even tell how far or how right. I mean, you just check their sugar randomly. And if they have more than 11.1 and is associated with passing frequent urination or frequent tests, you can also diagnose them as such. And then we have this new method. This is HbA1c. We call it a glycated hemoglobin. Hemoglobin in your blood binds to sugar and is an irreversible sort of binding. So we have a way of measuring it. If it's more than 6.5%, yes, we can. And the good thing about this is that it's a working test. You don't need to fast before you do it. And it actually also looks back into your sugar control over the past, 10 to 12 weeks. So it's also, so by these four methods, once you discuss, doctor will discuss with you, you can get an idea. But there's the in between, all right? People who are not frankly diabetic, we have not diagnosed them as diabetic, but these are people that when we leave them with time, they are going to have diabetes. And these are categories that we are interested in. So you catch them early because these people can actually reverse or postpone the diagnosis of diabetes, right? So we have the people that when you do their fasting plasma glucose to be between 5.6, 6.9. The cutoff for the diagnosis was 7. These people are in between. or you do the glucose tolerance test 2 hours after, and they are between 7.8 and 11.0. Okay, so you may have people that might have good fasting, but when they do this glucose thing, they will be impaired. So we have the two groups. The impaired glucose tolerance means that their system can't react very quickly and appropriately to sugar load. But with time, they get corrected. So by the time you are fasting them to check, they are back in the range. Okay. But we have some of those people too that have what we call the impaired fasting. Their fastings are not good. But if you do this for them, you'll be okay. All these are like people who eventually will develop diabetes. And once you catch them early and then you institute the appropriate measures, they will be able to reverse this. And I have Richard's Ostarios's full permission to even use him as an example, right? So this is Richard that had just a routine test. He didn't really have any problem. Routine test because maybe the dad is a diabetic, so he decided to just do it and see. And he was picked up having very good fasting sugars, but impaired glucose tolerance. Okay, and then you do this one, the one that looks back into 3 months and is bad. And that is where it's so important to catch them early because, in fact, he was even offered an option of drugs, medication, because he was really, really, and he determined to change lifestyle. So I don't know how many of you have seen him recently as compared to maybe a year and a half or 2 years ago. He put himself into a very good regimen of exercise and diet and lifestyle modification, shedding a lot of weight, picking up his exercise regimes. And I tell you what, you repeat a test in 6 months' time and everything is back to normal. That is why it's so important to be aware of this and then to curtail your early diagnosis. So thank you, Richard, for allowing me to give us an example. So screening, I'm almost at the end of it. Okay, screening, yes. Who can screen? I've seen that. I mean, for us, we are all in getting to our 40s and all that. So uh, we all can at least screen once in a while. If you screen and you are fine, every 3 years or 2 years you can screen. But you need to be aware and to want to screen a lot more. If you have any sibling or parent who is a diabetic, if you are a woman or your wife delivers a baby which is more than 9 pounds, if you have hypertension, because they go hand in hand together, or you do your cholesterol level and your HDL, which is your good cholesterol, is low, below 0.9, or your triglycerides are high. Okay, there are other conditions that when you have, your doctor might also want to screen you for diabetes. But as I said, getting to 40 is only wise that at a point in time you just screen and test. Now the important part, and then we are off. Preventive efforts. I've told you that the reason why we're doing the presentation and it's so important is that yes, we have a huge burden of disease in terms of diabetes as a non-communicable disease. It's almost becoming an epidemic, right? But there's a good news because a lot of preventive efforts can help stem this tide. And that one, maybe yes, it also maybe yes, slightly cost a bit of money because you may need to change your diet and all that, but it's far cheaper than having the condition. Okay, so investment of resources into early diagnosis, patient education, and prevention treatment pays off. It gives you longer life, increased productivity, and reduced cost over the long term. All right, so in trying that, reduce your level of alcohol, reduce your level of the things we love so much. Okay, I know, like oversized steak, pork chops. You want to have double cheeseburger, all right, with chips, coke, maybe twice a day because it's easy and it's around the corner. Smoking, I know, it's not a very huge problem, and then have more of exercise, good diet. We have what we call the Mediterranean diet. So for those of you who are also interested in looking at diet or changing your diet, you can just go Google the Mediterranean diet and look at the components, what it is. But we have our own local versions as well, okay? And to sum it up, this is the WHO fact on diabetes, okay? 347 million people worldwide have it now, and it is predicted to become the seventh leading cause of death in the world by 2030. 2012, it was responsible for the death of 1.5 million people around the world. And this is the part that I'm passionate about, that 80% of the death occur in low and middle income countries. And I've shown you why. Because the management is relatively expensive, and the management of the complications are even more expensive. How many people can afford like dialysis in this country of ours? Okay, or kidney replacement, or putting a stent or something in the heart. Okay, and as I said, it's the leading cause of blindness, amputation, and kidney failure. But there's still some good news that it can be prevented or at least postponed, or even when diagnosed and you understand it, well managed. So on that note, I thank you for listening, and sorry again for the late start. So I'm now open
Now
for
open for
questions.
questions.
Okay, good one there, Dr. Nkrumah. Thanks a lot. I'm not able to connect to the Q&A app. Dr. Nkrumah, do you see any questions on the Q&A panel, please?
Yeah, I see
Yeah, I
questions.
see questions. Okay.
Okay. So for
So let me
guys,
start.
one moment. For guys who have not been able to post their questions on the Q&A, please, you might as well post them in the Telegram group. That's on the Odadee 94 group. Sorry, anybody else, but it's only the Odadee 94 guys who have that capability. However, if you joined us with a computer, you should be able to post the questions and we'll take them. But I understand there are a couple of questions already. So,
Yes.
Dr. Nkrumah, please take it away.
Okay.
Okay.
So I'll start
So
with
I'll start with
is it Asantiano, right?
Santiano, right?
So
Okay.
which food should
So
we
which
avoid
food
and
should
which
we
ones
avoid
should
and
we
which ones
encourage?
should be
Okay.
encouraged?
So
Okay.
I think maybe that
So I
was
think maybe
before
that was before
I finished
I
my
finished my
presentation.
presentation.
So I think I've
So I
delved
think
into that
I've
a
delved
bit.
into that a bit.
Yes, yes. But
Yes, yes. But
for further
for
reading,
further reading,
you can also look
you
at,
can also
especially
look at, especially
hypertension, you can look
attention.
at
You can look
what we
at
call
what
the
we call
DASH
the
diet.
DASH
That is
diet.
for really
That is for
hypertension,
real.
but in diabetes as well. You just have to make sure you cut down on the calories, a lot more vegetables and fruit, cut down on your red meat, or even if it's white meat like chicken and duck, you deskin them, right? And then cut down on the amount of the fizzy drinks, carbonated, sugar, and a lot more, a bit of exercise as well, and maintain a good weight, BMI at least, at most at 25. It's difficult to achieve, but you can. So I'm not Kumi, thanks Rich. I need, I think I need to check to history in my family. Okay, yeah. So I'm not Kumi, yes, you qualify for screening, so you should screen. Okay, 1 in 4 do not know they have type 2. How often would you recommend one checks for these ones? Okay, so for those who qualify for the screening as I showed, these ones will usually, if you check and is negative, depending on the age. And if you are in the younger age bracket, maybe like the 30s, you can afford to check maybe once in 2 years, all right, or once in 2 years. But as you grow older, the frequency of checks should be more. At least every year you need to check. Yes, and the other question is about blacks being more prone to type 2 diabetes than other race. Yes, this is actually what the with the US studies, that's what has been found. It's the same thing with hypertension as well. Like the black Americans, they tend to have a higher prevalence of diabetes amongst, like, if you take the population there and the population that have diabetes, they tend to be higher than with the pure Caucasians. So between the Black Americans and then the I think the Latinos, all right? Yes, Asians do have Asians do have a problem with diabetes, all right? And it's all for us, and maybe for those Black Americans as well. The problem too has been that we've moved very quickly, all right, you know, to to a lifestyle that sort of predisposes that extra risk for us without maybe the necessary adaptation or not. Uh, and then there's a question. Yes, yes, yes. The prevalence studies. Yes, 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 yes. Done in males. How about women? Current stars in. Okay, is looking at it. Okay, maybe hitting 15 to 20%. Also, maybe the most current one that we have, we're still around the 6.467%. That would be somewhere maybe getting to the 2010s. I'm not too sure, but 20% will be very high. Maybe that one will be, might be, maybe if you do a selection of, I don't know, maybe a high class group of people, maybe. But in the general population, if you level it out with all the folks in the rural and all that, it brings it down a bit. So still looking at between 6 and 7%, maybe maximum 7.5. I think there are no more questions, Richard. Richard? Okay, okay. Oh, I'm seeing some more questions. Okay. Then let me answer that. I was just going to tell you that I'm done with the questions. Okay. So Nene Akofi sends a question. What benefit has alcohol in managing or preventing diabetes? Okay. So in managing and preventing diabetes, alcohol really has no proven benefit. Okay. The only exception is, the only thing is that excessive alcohol is been known to be a risk as well in developing diabetes. Yes. When it comes to like heart diseases and all that, I mean, there's been a bit of talk about the fact that moderate quantities of red wine, all right, may be heart friendly, because certain groups of people who have been taking it in moderation, have not been seen to have a lot of these conditions. But that is about it. It's still quite a debatable issue all the time. But alcohol in excess, and especially the hard liquors and the beers, have not been proven to be of benefit at all. Yes, coffee. But the red wine in moderation, yes, there's still a lot of talk on it. So, okay. And the Telegram platform. Okay, okay, okay. I'm coming. I'm coming. I'll look at it. Hello, Richard. The questions on the Telegram platform. Let me answer them. So I'll look at it and just answer them. Okay. Right. folks, give me just a minute. I'll just look at it, please. Uh, okay, 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 okay. 1 minute. Okay. Oh, okay. So lawyer's question. How much does it cost to screen? Can we organize a screening for this group? Oh, yes. For screening, I mean, if we buy our own, we can buy our own glucometer and then sticks. A glucometer should cost maybe about, that's the meter for measuring, should cost about maybe 150, 200. And usually it will come with a pack of, maybe if it's, let's say 200 or even 250, it will come with a pack of 25 strips. So you buy an additional set of strips, like maybe two additional set, maybe seven. So if you have 75 strips, it shouldn't cost more than 400 to do that. Yes, it's very possible. We can organize that. So we can see one of the days we can organize a screening, both diabetes, hypertension. We can do that maybe one of the Saturdays, and then we can it's something that we can easily do. We can even bring maybe our spouses, our friends. We can organize it. I mean, it's something that I think we should push. Maybe I don't know whether you have a health committee, but it's something we can easily do. Once we do that, I can organize it. Bring some guys in there, and then we do it. Yeah. Okay. So do I have to be worried if I have cousins who have a history of diabetes? So usually cousins, uh, you don't need to worry as much as if you have like a first degree, like maybe your siblings and your parents, all right? But if your cousins are having it from your uncles and aunties, yes, I mean you should just be aware of it, and anytime you have the opportunity, try and test. Yes. I have more questions if you allow me. Okay, so I saw something about erectile dysfunction. I'm coming. Okay. Can a diabetic patient have a good sex life? Yes, a diabetic patient can have a good sex life. But as I said, it all depends on how well the condition is managed. See, for example, for males, let me use the male for example. Erection depends on the integrity of the vessels in the penis that allows them to easily dilate, allow blood in, and then lock it up for erection to be maintained. All right. Diabetes, as I've explained, affects the integrity of these vessels to even manage that process. So if you have, and as you know, the type 2 diabetes, it may be quite insidious. Like you may have those impaired, sugar problems and going on for quite a while before you finally get to check. So sometime by the time you check, you may even have started having some problems already. All right. But having said that, I mean, once you pick it up early and you manage the condition well, yes, you should have a good sex life. Sometimes even on good management, you may have a few issues with erectile stuff, but yes, there are medications to help. But even for women and all that, it can actually reduce libido and all that, not just the like maintaining erection for men as well. Uh, Having the required libido and engagement for sex and all that. And it can be quite devastating. I mean, I'll tell you a story if you have time. I'll tell you a story. So I once saw this young guy. I think he was a type 1 diabetic, but at the point he was around maybe his late 30s. I mean, who got married to this other young lady, and I was working in Cape Coast then. So almost every 2 weeks, or this patient comes in, to the emergency with a problem with sugar. The sugar has gone so low or something. So At one point, it came and I decided to talk to the wife. Maybe that time the wife would have been in his late 20s, early 30s. And then she just pours out to me, okay, so this is a guy that the family friends, they got married because, the guy was growing and they went to see this lady's family. They look for the good girl, she's maintained herself and all that. They got married. Not knowing the guy rectally has erectile dysfunction, as a complication from the diabetes for that long. See? They didn't tell the woman. So they get married and the guy can't have erection, can't maintain erection for sex. And you can imagine the psychological trauma this woman was going through. Because to her, she can't also go behind her husband. She doesn't know who to talk to, what to do. So yes, if not well managed, the disease itself, can lead to those problems. Yes. But having said that, you can also have a very good sex life. So yes, just manage your condition as well. What okay, so I think Intercore is proposing that we can look into organizing this. We may, yeah, 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 yeah. It's something that I would very gladly encourage us to do. I mean, we commit, whether at the school, anywhere. I mean, I mean, it shouldn't cost that much at all to get it done. And it can be very important. And we can even organize to have some few health talks, maybe bring one or two people, talk more about diabetes, talk more about hypertension. So just some short sections like that. And then get ourselves educated. And then to be able to educate other people as well. So I agree somewhat. Uh, the 20th, we are meeting in the afternoon. Okay. Anyway, I mean, we can judge and see whether before the end of the year or something. But if there's even a time before the end of the year, I mean, the logistics won't be a big issue really, so we can manage it. Let's see. No, 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 no. You see, that's the problem with. So this is Ruth's. I'm responding to Ruth's comment about whether it reverts after the management. So, so that is the problem, with what we call this end organ damage. I will show you that slide again, Roach, if you're watching. So you go back there. Sorry, here. So a lot of these complications are very difficult to reverse. At best, you can just reduce the rate of progression or possibly halt. If you're lucky, there can be a few reversal if it is picked up early. But then apart from that, it may be very difficult. So something like the erectile dysfunction, not reversed. But for him, depends on how bad it is. So sometimes you can manage with medications, and sometimes you can respond to the medications. Yeah. So unfortunately, though, Rich, I should tell you, this woman, young woman, sitting in front of my office and crying. There's nobody she can talk to. The way these things are in our communities. I've been confronted with such a huge tax, you know, thinking she's taking very good care of herself, and then expecting that marriage will be bliss, and that's where she's going to experience sex and all that, and then you go in for that, sorry, and that's how you end up. So that's it. Okay, so wow, so Samuel is proposing that you will cover the cost for the machine. That's really cool. Yeah, yeah, yeah. In fact, he can if he decide to cover it, he doesn't. Once we use it, he keeps it and he uses it. I mean, when we need it at any point in time, he can give it to us so that it will also be of benefit to him. Uh, so that would be cool. And then okay, yeah, 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 yeah. Okay, so he makes a point about that would be a ground for divorce. Yes, 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 yes. I totally agree. I totally agree. But I mean, at the point I sent this woman to the clinical psychologist. to just help them deal with emotional problems and see the best way out of it. I was a young man too. I mean, I didn't want any accident on my side, so just kidding. I mean, okay, Stylus, I get you. Your mic won't work. Okay, so all right. The Jacob is looking at prostate cancer. That's fine. Okay. So I think that I'll round up. I mean, questions will come up. This is just a teaser, you know. So when questions come up, you can put it on the Telegram. I will respond to it on the Telegram. Okay. So I thank all of you guys for listening. It's been quite late. It's got late and it's been a long talk, but I hope you enjoyed it and looking forward to some health screening and subsequent health presentations. I mean, if the opportunity comes. So have a good night, have a good week, and Merry Christmas to all of you. Thank you. Bye.